Recording in
Thanks
progress.
very much for connecting. We'll get started straight away. My name's Oliver Morgan. I'm the director of the WHO Hub for Pandemic and Epidemic Intelligence, and along with Zoiler, I co-organize the Innovation Forum meetings, and we have a very exciting session today, which is from shared lessons to smarter pandemic preparedness and response. Innovative learning across LMIC health systems. Just as we get going, I'll make a note that we're recording this meeting really for note-taking purposes, not for publishing the recording. So please be aware of that. And also, as we get started, if participants would like to put their names and affiliations in the chat, it's a nice way to get to know other people who are online. So please feel free to do that. For those of you who've been part of the Pandemic and Epidemic Innovation Forum sessions before, we've now been running since 2022 with between 3 or 4 sessions every year. And the goal really is to bring together different stakeholders to talk about topics that might be outside of everybody's day-to-day work. And the intent is to really motivate thinking, engage in discussion, and think a little bit outside of our, let's say, normal zone of influence, to learn about different dimensions and aspects of pandemic and epidemic intelligence, public health, and health in general. And so you can see on the right-hand side, we've had a very wide range of different topics, some with kind of broad scope about kind of global issues, some with a kind of very technical focus, and all of them highlighting different aspects of the work that we're engaged in. So if we go on to the next slide, please, Alina, thanks. So we also have, since last year, a collaboration space. We have a community of practice for the Innovation Forum where everybody who wishes to engage can share information. There's a QR code here for people to sign up. And there are other communities of practice which people can engage in, as we see listed here. So feel free to sign up and engage in this space online with this and other communities of practice. Another thing that we started last year, which might be of interest, is we actually started a podcast series. And the podcast series for the Innovation Forum particularly explores how AI tools can be used for public health. And it's a kind of a format where I chat with some practitioners in this space, in the public health space, to talk about how they are actually using AI in their day-to-day public health work. So it's very practical and rooted in real-world applications. So feel free to have a look at that. And again, there's a QR code, and the podcast is actually also produced by Zoiler. So please use that as a resource as well. The forum itself continues to grow with a large number of participants from around the world. We have kind of global coverage at this point. The time zone is always a challenge for us. We try to run these sessions in a time zone that is more or less accessible to as many people as possible. But I acknowledge that for some people, it's very early in the morning. For some people, it's very late in the day. So a special thanks to those of you who are joining outside of, let's say, a normal work day rhythm. Similarly, we've got a huge number of different organizations that participate. And this is an attempt to capture some of those, but there are probably more that we are unable to capture just in one slide. But again, I think this shows the growing range of engagements that we have. So without further ado, I'm going to just kind of go through, what we're going to talk about. We'll actually then do a quick group photo, and then I'll hand over to Sara Bennett, who will lead the moderation of the session. So thanks very much to Sara in advance. And we'll hear a little bit from Sara about knowledge transfer theories and framing for the rest of the discussion. Please feel free to add your questions and thoughts in the chat as we go along, and also save up some of your questions and for the discussion afterwards, and feel free to engage. So with that, I think I'll invite those of you who wish to turn on your cameras, and we'll have a quick group photo, and then I'll hand the baton over to Sara. So I think, Anina, are you the online photographer?
Yes, Anina is here with me, and she will help us take a couple of pictures. Takes some seconds, so if you could give us a big smile. And I know it's a bit awkward, but maybe stay there for some seconds, and she'll let us know when we are done. Done? Okay, thank you, everyone.
Great, thank you so much. Thanks, Ola. Thanks, Anina. Okay, great. Well, let me hand over to Sara, and who's going to take us through the session, and she'll introduce herself as well as the other invited guests for the session. And over to you, Sara.
Thank you very much indeed, Oliver, and it's a real pleasure to be here today. So hello, everyone. My name is Sara Bennett. I'm a professor in the Department of International Health at Johns Hopkins University, and also vice chair of the department. And I think that we have a dynamic panel today that has really rich experience in the field of knowledge translation. So I'm going to start out just by introducing our panelists so that we can flow straight into the brief presentation and discussion. So co-moderating with me is Verena Struckmann, who's a research fellow at the Department of Healthcare Management at the Technical University of Berlin. And then we have 4 panelists from across the world, starting out with Tanja Kuchenmüller, who's the unit head, Research and Ethics Ecosystem Strengthening, Science for Health Department at the World Health Organization. Then from the Caribbean, Shelly-Ann Hunte, who's a research fellow at the Caribbean Center for Health Systems Research and Development, Faculty of Medical Sciences, the University of the West Indies in Trinidad and Tobago. And Sam Mbugua, who's an assistant professor of epidemiology and chair of the Department of Nursing at the US International University, Africa. And last but not least, Firmaye Bogale, who's the Director of Knowledge Translation at the Ethiopian Public Health Institute in Ethiopia. So as Oliver already reviewed, we're going to start out with a very brief presentation that I'm going to provide, and then we'll go straight into our conversation with the panelists. Next slide, please. So I'm going to be speaking broadly, trying to set the scene a little bit around knowledge translation. And I wanted to start the presentation with 2 quotes, which I find myself mulling over. The first is a quote from Keynes that says, "There is nothing a government hates more than to be well informed, for it makes the process of arriving at decisions much more complicated and difficult." And then we have an opposing quote, if you will, from Colin Powell, who says, "Experts often possess more data than judgment." And I think the truth lies somewhere in the middle of these 2 statements. Governments often appreciate evidence during decision making, but they also recognize that it's not the only thing that should shape their decisions. And on the other hand, I think experts understand that they don't have all the answers, and they need to collaborate closely with policymakers to ensure that there really is good judgment going into decisions. Next slide. So there's been a lot of work that has sought to look at the barriers and facilitators to using evidence, including research evidence, in the policy-making process. And this slide presents data from 2 systematic reviews on the factors that are commonly identified as barriers and facilitators in studies. And you can see at the top of both columns Personal contact between researchers and policymakers is key, as are the timeliness and the relevance of evidence. Interestingly, quality of research comes a little lower down the list, and political instability and power struggles, unsurprisingly, are common factors that present barriers to evidence use in multiple different contexts. Next slide, please. So the prior slide described the barriers between the research or evidence generation community on the one hand and policymakers on the other. But in practice, these two communities sit within a much more complex ecosystem, and neither of them are homogeneous. When we think about policymakers, for example, they span the gamut from technocrats with lots of experience using evidence all the way through to politicians who would likely approach evidence use in a very different way. I wanted to show this figure to give you a sense of the complexity of the evidence-informed policy ecosystem. Along the top, you can see the different functions involved, from setting priorities about what research should be done or what evidence collected, through the whole research and dissemination process. Some evidence or findings will get picked up and amplified and will ultimately inform the policy-making process, whereas others may just fade away without really being used. In the middle row, we see the mix of different types of organizations, and I saw from Oliver's slide earlier that you had already talked about some of these, for example, the media. And you can see that there's really a multiplicity of actors here that play a role creating, disseminating, and amplifying evidence, as well as using it in the policy process. So during the past 30 years or so, there's been a lot of effort to support evidence-informed policy, particularly by investing in knowledge translation. Next slide, please. And knowledge translation can be defined as the synthesis, exchange, and application of knowledge by relevant stakeholders to accelerate the benefits of global and local innovation in strengthening health systems and improving people's health. It involves purposeful efforts to address barriers to evidence use, and typically it encompasses multiple stakeholders and both health and non-health evidence. So bringing evidence, for example, around the financial situation, economic data may also be critical. In terms of the health sector and the adoption of knowledge translation mechanisms, often it's taken the form of a knowledge translation organization or platform, and we're going to hear today from some people who've been involved in setting up and running such platforms. Next slide, please. This slide from John Lavis, who has done a lot of work in this space, talks about the different models for linking research to action. What is the relationship between the research users and the research or knowledge creators? Much of the energy has really been around Model D in the bottom right-hand corner here, that looks at entities that can help integrate and align the efforts of those generating research or evidence with those who need to use it for policy and decision making. And today we're going to hear about specific country experiences with knowledge translation and approaches to strengthening the institutionalization of evidence-informed policy. Before I go to the panel, however, I wanted to raise a question concerning how evidence use during an epidemic or pandemic might differ to that during normal times. Next slide, please. So there are three primary factors that occur to me, although you may think of additional points. First, during an outbreak, especially of a novel virus, there may be less certainty around the nature of evidence. Second, given the high stakes and the uncertainty, there may be greater conflict over evidence and what it means. And third, there is often an urgency to decision-making during a pandemic that can be quite different to during routine policy making. Next slide. So there's a very interesting, quite recent paper by Greenhalgh and Engebretson that argue for 5 shifts that they suggest need to take place in science policy relationships during a crisis. First, they argue that we should not be overly dependent on science, but also use our common sense. For example, adopting masking policies because the costs of doing so are low, even if the evidence on impact is not particularly strong. Second, we need to be able to act under uncertainty, and this may mean introducing new measures and simultaneously conducting research and evaluation on effectiveness. Third, they suggest that we need to get away from the notion of hierarchies of evidence, the sort of thought that randomized controlled trials that examine effects are always the best source of evidence. We also need to examine evidence about questions such as acceptability of the interventions and feasibility. Fourth, during COVID, it often seemed like we had conversations at cross purposes with each other, and that may be partly because different stakeholders had different frames in their mind. So, for example, public health frames might prioritize minimizing deaths and protecting hospitals from an influx of patients, whereas economic frames might balance this more with preserving livelihoods. But I think it was sometimes unclear what frames we were using in our debate, and so we need to have more discussions about which outcomes are most important and how do we weigh these different outcomes against each other. Finally, the paper suggests that we need to do a better job at integrating people's values and preferences into our decision making. So I think that looking forward, we have a full and exciting agenda for discussion. And I'm going to start out by asking each of our panelists to give us a very brief flavor of their work by describing the most innovative aspects of their research, just so we can get a sense of what they're up to and what they're involved in their day-to-day lives. So maybe if we can go to the next slide, and Tanja, I could perhaps hand this over to you. I know that you're going to be reflecting a little bit on work WHO has been doing in institutionalizing evidence-informed policy processes.
Yeah, thanks so much, Sara. And the work that we're doing at WHO focuses not only on research. We do have a recently established global research agenda on knowledge translation and evidence-informed policy. But much of the work, in fact, is focusing on operational issues linked to knowledge translation. And I would like to briefly introduce WHO's Evidence-Informed Policy Network, Epidemic, which was specifically established to support the institutionalization of evidence use and decision-making. And that means moving beyond individual or ad hoc use of evidence to its embedding evidence systematically into the structures, processes, but also the culture of health systems. And so EVIPNet supports countries in strengthening their capacity to ensure that evidence is, as much as possible, really routinely used and consistently used to inform policies, programs, and investments as well through the establishment and of national knowledge translation platforms. You mentioned it, Sarah, which are national science advisory bodies, one could call them also like that. And this contributes not only to better decisions, but also to strengthening trust in science and ensuring that global evidence, such as WHO's norms and standards, are contextualized, or that localization takes place to national realities. And a key part of EVIPNet's role is also to make sure that across the evidence ecosystem, there are partnerships strengthened. Sara has shown the real diversity of the ecosystem. And it's important for us to linking ministries with health, academia, research institutes, and allow for this cross-evidence ecosystem collaboration between producers, intermediaries, users, but also across various evidence decision-making processes, so guidelines development, health technology development, or what EVIPNet is doing in the evidence-informed policy space. Then on the right-hand side of the slide, you see a framework which illustrates what we understand under institutionalization and what it requires in practice. At the center is knowledge translation, so the function that connects evidence to decision-making. Sara had also provided a very clear definition of what knowledge translation is, and we apply at WHO the same one. But the sustainable knowledge translation process very much depends on having an enabling institutional setup or conditions. And on the slide, you see the framework that we're applying, which was published in a critical interpretive synthesis, so in a peer-reviewed journal, based on which we developed a WHO guidance, a checklist. And this framework includes various domains of institutionalization that ideally throughout time increases in maturity. That's on the one hand, governance to provide formal mandates and accountability in this space, standards and routine processes to ensure that evidence is really systematically integrated into decision workflows. Leadership and commitment are essential, not only to trigger off change processes, but actually to sustain them. Resources are essential. We often speak about financing and financial resources, but just as important is the workforce and the technical capacity that need to exist to implement, monitor and evaluate knowledge translation processes. And then lastly, also culture. So to create an environment where evidence use is expected and valued, and partnerships are put in place across, as I was saying earlier, which is promoted by EVIPNet across the evidence ecosystem. So importantly, for us to keep in mind that institutionalization is not just confined to ministries of health alone, but it really depends on a wider ecosystem, including research institutions, academia, civil society, and international partners. And EVIPNet here plays a critical role in strengthening these connections and embedding evidence use within national decision processes. So ultimately, EVIPNet is a key instrument at WHO in the process of strengthening evidence to policy mechanisms to ensure that evidence is more systematically, routinely, and transparently used in policy to lead to better health outcomes. Thank you, Sara.
Thank you so much, Tanja, for giving us such a great overview of EVIPNet. And I realize that EVIPNet has done so much really to help promote and strengthen the use of evidence in policy making and decision making across the world. I think you gave a really nice overview of the kind of different activities you were currently involved in and how they were relevant to national governments. So we're going from a global perspective to much more of a regional perspective now. And I'm going to ask Shelly-Ann if she can reflect on the same question. What's been up to recently that has been most innovative and exciting in the context of evidence use for decision making in the Caribbean? Over to you, Shelly-Ann.
Thanks a lot, Sara. So maybe I can have my slide up. All right, so I thought it would be really fitting this morning to just share our journey as an evidence intermediary. We consider to be a relatively young evidence intermediary, and our journey began in 2016 with a pivotal conversation between the then Minister of Health and the Dean of the Faculty of Medical Sciences at our university. And during this conversation, a stark observation was made. The university was producing a substantial quantity of high-quality research, but it was not addressing the needs of policymakers or the questions policymakers needed answered. This exchange catalyzed action. A feasibility study was commissioned, and this study included a desk review of Caribbean centers to identify knowledge translation service gaps. We also did a needs assessment exercise followed by extensive stakeholder consultation. So in 2018, our center was formally established to bridge the gap between research production and use. Our first step was simple. We wanted to listen. We conducted needs assessment exercise with the Ministry of Health and other social sector ministries to understand how evidence was and was not being used in policymaking and other decision-making processes. We explored their perspectives on evidence-informed decision-making. We identified barriers to the integration of research evidence in policymaking processes, and we mapped their training and capacity gaps. This groundwork led to customized training workshop for each ministry, and this was followed by a more intensive 6-month evidence to policy fellowship program. Along the way with these stakeholders, we co-produced knowledge translation products and conducted stakeholder dialogues. Early in 2020, we sought to establish a rapid response service to synthesize and package in a concise manner locally contextualized evidence into briefs tailored to policymakers' questions that could be delivered between 3 to 30 business days. Such a service we recognize to be very important during a public health emergency, as policymakers need access to timely evidence to make these rapid life-saving decisions. However, we were not successful. We were unable to secure the seed funding from the government or to secure interest and collaboration to have this set up. During COVID-19, again, we offered rapid response briefs and rapid evidence syntheses to the government and policymakers, and this offer was not taken up at that time. So we pivoted to forming a local FMS research group that would generate local contextualized research evidence to inform prevention, treatment, and mitigation measures. When global discussions, including those from WHO, highlighted the need to prepare for future public health emergencies, we co-produced an evidence brief for policy and conducted a stakeholder dialogue focused on addressing mental health and the psychological impact of public health emergencies on healthcare workers in Trinidad and Tobago. The focus of our evidence brief for policy was very clear. How do we learn from COVID-19 evidence-informed strategies and mitigation measures? And how do we prepare proactively for the next public health emergency? More recently, with the support of WHO Epidemic, and I really must say thanks to Tanja for this, and the University College London, we took a step back to assess the bigger picture. We conducted a comprehensive assessment of the health evidence ecosystem in Trinidad and Tobago to analyze the state of evidence-informed decision-making. We also were able to assess institutionalization across the 6 domains Tanja mentioned, and we were able to develop an action plan with concrete actions for advancement. One overarching recommendation that emerged was the establishment of a committee or national council that could provide strategic oversight, coordination, and implement the resulting action plan that came out of this assessment. This action plan would be designed to strengthen the routine use of evidence, not just during normal operations, but also during emergencies. So just to close, our journey has evolved from addressing KT service gaps to building capacity and lobbying for rapid response mechanisms while co-producing KT products. And now we are working towards systemic institutionalization, and we continue to build. Thanks, Sara.
Thank you very much, Shelly-Ann, for such a clear presentation. It's really interesting to understand about how you've approached this so systematically, from understanding the current environment to thinking about how you can strengthen it. And thank you also for raising the really important point about financing and how do you ensure financial sustainability. I can see a few comments and questions already landing in the chat. Please do use the chat box to raise thoughts or questions that we can put to the presenters when we open it up for discussion. But next I'd like to go to Samuel Mbugua. And Sam, I think you're going to talk about a country experience now, or maybe even a more local one, a county-led knowledge translation model. So over to you.
Thank you very much, Sara. Hello, everybody. So I'll quickly just get into our current ongoing work on a county-led knowledge translation model for operationalizing the use of evidence in day-to-day policy and decision-making. And basically, we started initially by thinking about who would be the technical sort of officers that would help us leverage and see how we can better ingrain the use of evidence in day-to-day decision and policy making. And so we went ahead and established and operationalized a county level sign-up task force, which basically refers to a science in evidence use and policy making task force, whereby we signed charters with the leadership, this being at the governor's level, with the key goal being to embed evidence use into county planning and budgetary lines, as well as support in the planning and co-creation of a summit that we had, a maternal, newborn and child health summit, as well as co-development and co-creation of a science for policy curriculum. This quickly built momentum and sort of led to the embedding of evidence structures within what we call the annual work plans at the county level. Fast forward, we had several activities with partners within Moy University, the larger AMPATH group, as well as at the county level, whereby we were working with 2 primary counties. And this led to a contextualized curriculum that leveraged on key competencies drawn from, again, thanks to Tanja and team, from WHO EIPM checklist to build on routine capacity for various decision makers and technical staff, basically trying to use what they do on a day-to-day to ensure that there is better use of evidence in their policy structures, as well as guiding decisions that are made. We also have plans to leverage on artificial intelligence to speed up synthesis of various policy briefs, as well as critically seeing how we can improve accessibility of local evidence that is drawn from research, drawn from different reports that have been put out, as well as critical guidelines to guide maternal child health, as well as the larger health infrastructure, while supporting real-time decision-making, while using the county health management team as the technical team to help sort of build this. So the next critical steps that we aim to amplify is the building of knowledge to action through various activities. One, previously in the last year, has been the Maternal Child Health Summit, which brought together different stakeholders sort of to try and build the research and policy dialogues, cross-border policy dialogues as well, and evidence-driven documentary that we have used to elevate significant issues both at the county and as well as national level, whereby we brought stakeholders from national government down to the county to sort of see how the country level sort of policies speak to more of the technical implementation bits, as well as building on global conversations through the Empath Knowledge Translation Code to see how we can better amplify this. So this is just a quick synopsis of what we have been doing from the county perspective, seeing how we can build better and more robust knowledge translation models. Thank you. Over to you, Sara.
Thank you very much, Sam, for that very interesting experience from Kenya. And I think, given devolution in Kenya, this sort of question about how do you build capacity really at the local level for evidence use is a really important one that I hope that we can come back to in the conversation. So last but not least, I'm going to go to Firmaye Bogale, who's going to be talking about experience in Ethiopia and through the particular lens of COVID-19. So I think that this will be very relevant to a lot of our participants. Over to you, Firmaye.
Thank you, Sarah. Thank you. Yeah, so as mentioned, I will try to reflect on the evidence to action system in Ethiopia with the lens of COVID-19. But before I go to that, so I come from the knowledge translation team that is working in the National Public Health Institute, that is working on the interface between research and evidence and mainly supporting the Ministry of Health. So for a long time, we have been grappling with different frameworks and models to assess the evidence ecosystem in Ethiopia. And we were really happy when the WHO checklist came out. So we sort of adapted that and utilized that to see where the evidence ecosystem really was in. And we tried to look at the 6 domains that were explained earlier by Tanja. And I'll just point out very few pertinent features that we have seen and how that went along with the COVID-19 experience. So in the Ethiopian system, we have different structures and institutional mandates that are specifically working on knowledge translation and supporting EIDM. And in addition to that, what we saw worked really well in the system were structures like technical working groups, research advisory councils, and also specific platforms that are designed for researchers to come out and present their findings to high-level decision makers. You can call it like a brown bag sessions, and that we're really pushing decision making and evidence platforms or interface forward. And looking at the capacities that we have in Ethiopia, of course, there is a growing capacity on knowledge translation and EIDM, but we see that to be very concentrated in few institutions, especially the governmental ones, and we are working towards diffusing that to subnational and regional and sub-regional levels in the Ethiopian system through TOT and different kinds of capacity building in knowledge translation outputs like policy briefs, rapid reviews, and what is really the concept of knowledge translation on its own. And that takes me to the tools that we have. Of course, in line with the different structures that we have different tools and processes. But the problem that we have seen, and I think many countries that are working on knowledge translation would relate, is that these tools are not really standardized and harmonized, which really creates a barrier when you bring it forward to decision makers. And this is also something that we're working towards with the health evidence network that we have in Ethiopia towards, bringing together these tools and harmonizing them. So finally, I would reflect on the evidence itself. So in our system, we have a fairly strong surveillance system from subnational to the national level. But the main challenge comes in when you're trying to bring that information and data and blend it with that of different kinds of evidence types. It could be evaluation or research outputs, and synthesize, triangulate, and contextualize that for decision making, which takes me to the COVID-19 experience. So as you all remember, COVID-19 was a situation that really necessitated us to move away from the business as usual, where we would be pushing information and data to decision makers. And it led us directly to the active knowledge translation process, where it was possible for us because we had established a dedicated knowledge translation team in the emergency management system within the planning session. So this helped us to have a dedicated team that was working on a real-time evidence translation and supporting the decision makers. And that actually reduced the demand-supply link that usually takes maybe days or months to hours. And this was a huge sort of learning or lesson where we have seen that the system itself is really able to have or to hold a blended evidence to action process within the routine health system. But I can say that, looking now on the COVID experience that we've had, I cannot say that we have fully leveraged the momentum that we actually gained during COVID-19 because of different challenges. And hopefully what we're doing now is working towards institutionalization by leveraging on the lessons that we've gained from COVID-19. But of course, this would need to work on 6 of the domains, capacity building, and blending that together into the current exercise of working not only in crisis, but also in peacetime processes. I'll stop there. Thank you.
Thank you so much, Firmaye. A lot of really interesting insights there that I hope that we have the time to follow up on, including these sort of challenges around tools not being harmonized, and how do we build upon the momentum that was built up during COVID-19. So thank you to all of our panelists for giving such engaging introductions to their work. I'm going to hand over to Verena in just a moment to sort of take forward the next round of conversation, but maybe just to reflect on some of the key themes that seem to come out of that conversation from my perspective. I mean, one, I think a continuing concern about how we build sustainable knowledge translation and platforms that are both fit for purpose during emergencies as well as during normal times. Perhaps a sort of continued need for tools and mechanisms to assist with decision making and the organization and collation of data and its translation into policy. And I think, Sam, you also mentioned sort of scope for AI, and I think that that's a really important, perhaps forward-looking agenda that we haven't yet covered. So I think a rich ground going forward for the discussion. But Verena, maybe I can hand over to you at this point for the next round of conversation.
Thank you very much, Sara. And thank you very much to our 4 presenters who gave brilliant insights into their different stories of how they went into their various and innovative approaches on how to very often systematically approaching the operationalization of evidence to policy translation. And when we want to look on how those ideas can potentially be applicable to the response to public health outbreaks, I'd like to start with the example Tanja provided. She began the story from a global perspective with introducing the Epidemic and also the WHO checklist on the routine use of evidence in policymaking. And what we've realized already when it comes to the translation to public health outbreaks and the response here, for example, Epidemic is using and providing help with the formalization of protocols, which can trigger rapid evidence synthesis, and as well as the WHO checklist, which is really helpful in strengthening response by embedding structured evidence used to the entire decision-making processes. And there, the applicability it brings is in different forms, as Tanja already informed us, for example, with the rapid evidence-informed decision-making to support rapid evidence synthesis, and also providing structured risk-benefit assessments. And it reduces a policy lag here by the institutionalization with various institutions and strengthens preparedness, as well as the example we've received from the Caribbean, where Shelly-Ann began that the research output has been there, but was not reaching the decision takers. And how can this be used to respond to public health outbreaks? Was also described very clearly that with the developed Action Council functioning in the role of a broker between researchers, decision makers, and implementers, and also the production of the various evidence brief and knowledge translation products, what's really helpful in this regard. Thereafter, we moved to Kenya, where Sam showed us that it is really a very favorable basis to have different actors on board from the beginning on, with the Ministry of Health, which signaled the alignment with national policy priorities and also therefore the potential scalability. And thereafter, we also moved to Ethiopia, and it really, you demonstrated particularly the shift from the formerly reactive and ad hoc measures to this more structured and routine health systems approach, and embedding it into routine care. And these insights from this experience also show that integrating data, fostering multi-stakeholder collaboration, and ensuring political will were the critical parts for transforming evidence into rapid and also there during COVID life-saving actions. So the urgency forced system to move from passive evidence production to the active knowledge translation to answer all the rapidly evolving questions. So there are many lessons to be learned how your examples can be used to respond to public health outbreaks. And beginning with Tanja, I would like to ask you to briefly elaborate on how your examples and the WHO work can be integrated into interactions with decision makers, and whether you have any success cases in mind, and maybe also can briefly refer to limitations. So over to Tanja, please.
Thanks a lot, Verena. So your question was how the work has been integrated with decision makers, yeah? So that just to repeat the question.
Yes.
Yeah. So, I mean, decision makers are very much the center, at the center of the work that we are undertaking at WHO in knowledge translation. And I think also speak for the countries that this is the same. They're the ultimate users of the evidence that is being provided by knowledge translation platforms that we are supporting being established or strengthened at country level. And they're not only a recipient, they're very much also part of the co-production process, so deliberative processes, participatory approaches to allow for evidence not just being passively brought to the attention of decision makers and then expect that to be used in a linear process. So Sara also highlighted the push approach as one of the 4 approaches that were developed by John Lavers and colleagues. That's definitely an important aspect of knowledge translation. So allowing for researchers and decision makers to package evidence in a user-friendly way that it's easily understood and can more easily be used by decision makers. We have heard from the countries that an evidence brief for policy is an important tool in this context, but much more, and again, referring to Sara's presentation earlier on the barriers and facilitators of research use, it's very much the personal contact between researchers and decision makers that allow for building trust, that allows for building relationships, so that then evidence can be more easily be accessed, can be brought in a way to the attention of decision makers that is again meeting the needs in terms of relevance, in terms of format, but at the same time also where decision makers can highlight their evidence needs and their priorities. So again, bringing researchers and policymakers together on an individual relationship basis, which was highlighted in the slide that Sara showed, is one aspect, but even more importantly, we believe is the institutional aspect. So allowing for relationships to be developed in a systematic and systems manner, so that institutionally we have the evidence generation sphere being interlinked with the user sphere, but not only as separated sphere, but actually really bringing them together to form a joint ecosystem that allows for, as I said earlier, for co-production processes. So, I mean, if I were to summarize, it's really the work that we are promoting with EVIPNet and with knowledge translation is to serve decision-making needs, to improve decision-making and allow for better health outcomes, with decision makers being very central, not only as users, but at the same time also as producers, and sharing their tacit knowledge, giving them voice for their experience, which is very important to be taken into consideration in situations of crisis where evidence is uncertain. So not only making sure that the uncertainty of evidence is clearly communicated, which is central in crisis situations, but also allowing them to actually be part of the co-creation process and promoting and strengthening the pluralism of evidence that also was part of Sara's presentation earlier. Thank you.
Thank you very much, Tanja, for highlighting again also the importance of building trust and building the relationships between researchers and policymakers, decision takers during non-crisis times in order to be able to function well in outbreak or crisis times, and in order to have this really joint facilitated process there. And therewith, I would like to ask Shelly-Ann as well, from the Caribbean perspective, how your work, which you have created there with the Knowledge Brokering Action Council, so to say, can be, what else can be done to increase the interactions with decision makers, and what are the limitations you've experienced so far?
Okay, and just to give some clarity, we have not yet formed the Evidence Action Council for Health. So that's something we plan to do. We're finishing up the report for the assessment of our health evidence ecosystem, but that was the main recommendation. And, you know, really just want to say Tanja for this, to say thanks, sorry, to Tanja for this. During one of our stakeholder group meetings, she suggested that, you know, we pull this inter-institution committee together that will proactively promote and lobby and advocate for the work regarding institutionalization of EIDM in our country. So that's one of the next steps. So just to answer your question, you know, one of the things that help us a lot is this co-production. At the center, we utilize the integrated knowledge translation framework, which really focuses on collaboration, capacity building, and co-production. And that's one of the ways in which in a resource-constrained setting, we're able to achieve a bit of impact. Regarding the limitation, it's always political will. We recently had a change in government administration, and you know, sometimes it seems like we're starting all over again with respect to lobbying and sensitization and awareness and training and capacity building, because now we have new policy actors. So that's one of the major limitations, nothing that we can't overcome. Other limitations, of course, always has to do with resources. You know, we are resource-constrained setting. We are in a resource-constrained setting. We are a developing country. And we also consider to be a small island developing state. So those are some of the challenges we face. But we do have what we identify as evidence champions within organizations, such as the government ministries, as well as our regional health authorities, and within some universities as well. So it's about bringing these persons together and promoting for KT and EIDM and working together. Thanks, Verena.
Thank you very much, Shelly-Ann, for elaborating on your particular case, and also for highlighting that this process takes time in order to develop the required structures adapted to the needs. And thereby, I would like to move to Sam and to your example provided from county level from Kenya. What do you think in terms of how can your work and this project be integrated even more into interactions with decision makers, policy makers, and maybe what are the limitations you already faced and how you would like to overcome them?
Thanks, Verena.
Thank you.
Great question. So I think I'll start with the latter on probably some of the critical challenges we faced. And this, I think I'd like to highlight primarily has been getting the right political buy-in for this initiative and seeing how we can sustain the momentum throughout. And this has elicited critical discussions on how we can align with various political priorities depending on which cycle we're in, being the fact that we're about to go into an electioneering cycle next year. So we need to think about what this means in terms of sustainability and how we can best align to most of these political ideologies, as well as to building on a supportive climate for this. Some of the key mechanisms that probably I think we have tried to have a workaround, especially in protecting evidence to policy processes in line with institutionalization, has been using various knowledge translation platforms, from using the local research committees within the county governments to also increasing the legislative anchorage through the annual work plans, and also creating a process of routinizing various evidence-based workflows through policy dialogues, especially as we try and change the mindset from the perception that evidence is necessary to more of to rather having it more as a critical component in every decision and policymaking cycle. Part of the also seeing how we have tried to use what is already there has been sort of building capacity around this by using various interdisciplinary teams, such as bringing together different stakeholders through a maternal child health summit, for example, to try and build a steady ground in which there's consensus on what kind of evidence we need to use in various decisional policies, as well as institutionalizing cultural change and also creating mechanisms for feedback through ensuring that there's more community participation. Because our entire program has been sort of trying to increase scientific citizenry. So this sort of helps us build more robust mechanisms, even as we think about aligning with various initiatives, especially around preparedness to the next wave or next outbreak. Also, part of the work that we've done has been to strengthen cross-border health by having dialogues across the various counties and even the countries, even with our neighboring countries in the region. Thank you, Verena.
Thank you very much, Sam. And you also highlighted the need for this cultural shift and the perception of the evidence use, that it becomes part of formal decision processes and not really dependent on individuals. And you also highlighted a limitation which quite often occurs to endure continuity despite political turnover. And I guess Sara will come back to these aspects and others during the discussion in the end once more. But before, I would like to give the word to Firmaye from Ethiopia to provide also some insights into your example you provided, particularly during the COVID-19 pandemic, and also, of course, thereafter, how would your work can be integrated more into interactions with decision makers during a public health outbreak, and what are potential limitations here so far, or what are your success stories, how you've overcome them? Thank you.
Thank you, Verena. So I would say one of the very enabling things that helped us to have the learnings and the success during COVID-19 was the fact that we had a dedicated structure and mandate to act in the system as knowledge brokers, and to have the ability to co-create the evidence and the translation process with the decision makers. That also allowed us to have this contextualization as we were set in the system for over 15 years now. And we had an already existing system that allowed us to have this learning that was ongoing. And with the emergency happening, we were able to leverage from those learnings and the structures and the mandates that we already had. But I want to emphasize that while we're talking about the successes that we had during COVID-19, it was not without challenges. And that it was a very relational space. As you know, knowledge translation, even though it is embedded in evidence, it is also a very trust-based and relational process. And the fact that we had that rapport beforehand was also something that was supportive. And what I want to emphasize again before I conclude my point here is that even though we had that emergency and sense of urgency during COVID-19, it has clearly faded over time. And one of the things that we believe, or we're working towards, to keep that, at least if not urgency, to keep that momentum, could be attaching the use of evidence with accountability. But another question lies: how do we bring in accountability, real accountability, with the use of evidence, especially in the health system, is something that we're still working on. And another thing is also the institutional sustainability. As I mentioned earlier, we have infrastructures in place. Of course, they are having different challenges with the global situation that we have now, but at least having that embedded infrastructure really helps to have an embedded system, a routine system in the process. So I would say overall, one of the major things is that we had an already ongoing mandate and a clear position in the health system to provide a knowledge translation process. Thank you.
Thank you very much, Firmaye, and thank you to all of you to reflect on this aspect of your work very much. And when I look at my notes, which I have taken during the last minutes, I see very often the words coming up. If it would be a word cloud, I think we would see co-creation, co-production, and collaboration and cultural shift very often. And all of you highlighted that this is why institutionalization and really transitioning from crisis activation to routine embedding becomes really the central way forward here. And to routinely use evidence briefs or dashboards or frameworks consistently across different programs and sectors and decision makers, in the end, as all of you highlighted, beginning with Tanja, to develop familiarity and also trust among each other, and that evidence becomes procedural. And with this, I would like to hand over to Sara again.
Thank you so much, Verena, and thank you for that excellent round of reflections. So we're now at a point where we can open this up to the broader audience. There have been a number of questions in the chat, which I will come to, but also to encourage you, if you would like to ask a question, make a comment, please keep it sort of focused on the topic in hand, but please feel free to raise your hands and we will get there. Sa, you posed a number of different excellent questions in the chat. I'm not sure if you're still on the webinar, but if you are, I wondered if you'd like to pick your favorite question to pose to the panelists. Isatu, you were there? It's disappointing if ESA 2 has dropped, because there was a whole stream of great questions that came in from him. Maybe I can raise just one which sort of struck me, which was really asking about the extent to which we were seeing that health systems were acting as learning health systems. And in particular, he was asking about the conduct of after-action reviews. And I wondered, to what extent any of your platforms had been involved in those after-action reviews. And I'm not necessarily going to go through each and every panel member, but if someone would like to comment on that and what happened in their context, that would be great. No, Shelly-Ann, or actually, Firmaye, you talked quite a lot about the COVID-19. Do you want to reflect on after-action reviews in Ethiopia, maybe around COVID?
Yes, specifically during COVID. So yes, our team was involved in the after-action review, and we were able actually to support the team as well, as we are an evidence synthesis team. Yeah, so we were able to involve in there and also bring in. So we had different types of evidence that were coming in, as you know, during the after action and also the interaction. We were able to gather primary data and also leverage from the other systems that we were looking at. And of course, it was a huge learning that came from that for specifically the response side of things. But I wouldn't say that it was a huge learning that came out for the knowledge translation process itself, as the of course one of the I would say, for a lack of better word, domain of the assessment that we did was on evidence to action, but I wouldn't say it was the huge focus on that. But moving away from even the COVID process, we have a system and the knowledge translation system, even though away from the crisis mode, when we're working in the peace time, we have an MNE that we run. Of course, it can be strengthened, and it's one of the global initiatives that are happening in different spaces where we have this void of learning in the knowledge translation process. So of course we have a learning process, we have a reporting, especially for instance if we have a policy brief that is developed and we have provided that policy brief and we have conducted a dialogue, we have a system of assessing if that has been really useful in the system or have been applied. And if it is applied, what were the factors that were helpful for that? But that is not an easy thing to do. It is cost intensive and also needs an integrated system. We're trying to build it, but I wouldn't say it is one of the strongest features that we have.
Thanks so much, Firmaye, partly for reminding us about the importance of sort of understanding how effective these interventions are. But I also really appreciated your reflection that evidence to policy processes were not a central part of evidence to action reviews. And I think that's a sort of prompt that maybe we should think about making them so that we learn more as we go through these processes. There was also a comment from David Mwenda in the chat about AI and leveraging AI. David, I don't know if you would like to unmute and ask that question. If not, I can ask it on your behalf. And I was thinking of directing it towards Sam, because Sam actually raised this in his comments, but others on the panel, please let me know if you'd like to chip in. No sign of David. I think you're shy. I think that's what's going on here. Sam, David was sort of saying it's really interesting to leverage AI and public health intelligence, as well as sort of moving towards greater digitalization of tools and potentially automation of procedures. And I think the question there is, what do you see as the next steps in this direction? What do we know? What do we don't know? Have you got any reflections around that, Sam?
Thanks, Sara, and thanks to David. And I see he says it's on transit, but thank you for a good question, David. So based on sort of the fundamental work we've done around use of AI in sort of this evidence synthesis space, we see artificial intelligence having a great vast potential in transforming how decisions are made or policies are made, because it improves the efficiency and the processes of which data-driven decisions are made. And this helps to sort of show new sort of insights in how different parameters come together, different indicators, different even felt needs across the population, across the communities, and how we can draw these insights closer, especially borrowing more into qualitative bits to try and amp up what is already there based on quantitative parameters. I think artificial intelligence is one of the most potentially revolutionary components we've had. And I think most of our work has really been around seeing how we can use generative AI as well as large multimodal models and seeing how this can help increase accessibility and give real-time sort of prompts as to what are the low-lying fruits we can use to quickly make decisions that are impactful to ensure that there's efficiency in use of resources, and also see how we can use the same platform to increase the mechanisms we have for evaluation and regulation of different sort of service level indicators. But then there's always the question of how effective and also the ethical use of artificial intelligence, bringing in bits about trust and maybe how do we stop artificial intelligence from creating pockets of misinformation through hallucinations, etc. I think if we can establish adequate and comprehensive safeguards around this, then I think this would probably be our next sort of big right-home message on how we can intensively use artificial intelligence to create more data-driven, evidence-informed decisions and policies. Thanks.
Thank you, Sam. Really excellent reflections there, and apologies to David, who's in transit apparently. So that had a very good reason why he was unable to unmic. I think, Sam, your reflections are really interesting, and I think, as so often with AI, it's this balancing act between the huge opportunities on the one hand and the risks on the other. You talked about, the risks around misinformation, but also it worries me about the extent to which AI undermines some of these personal relationships that we know are so central to evidence-informed policy. I'm going to go to Oliver because you've put your hand up. There are more questions in the chat, which I'll come to in a minute. But Oliver, would you like to go ahead?
Yeah, thanks, Sarah. I was kind of curious from the panel about how we can support, let's say, either ministries of health or public health agencies commission research more effectively, and I don't mean the type of research. I mean, I guess I'm thinking about implementation research. So we've heard a bit about after action reviews, which are critically important, obviously once an event has happened, but somehow it's always a struggle to do the research in between the events prospectively and to kind of build strength. Otherwise, we're just always doing the reactive type research, and we fall a little bit into that that challenge of always preparing for the last outbreak or the last pandemic in this case, and not thinking forwards. So, but it strikes me that public health entities are not, obviously they're not the science ministry and they're not necessarily research entities themselves, and it might not be so easy to commission research, either framing the question adequately or even, and then I guess finding funding and then going through a selection process to select a research entity to do the work for them. What kind of pathways could we think about and construct that could be helpful in that regard? So it's kind of a broad question, I guess, for anybody online, but also for anybody on the panel as well.
Tanja, I wonder if you would be in a good position to start reflecting on that. Oh, and Shelly-Ann, you've unmuted. Maybe I'll go to you first and then to Tanja, if that's okay.
Sure. And maybe, Oliver, my response is more to do routine research as opposed to implementation research. But one of the things we had done in Trinidad and Tobago is we hosted a reverse research day where we allowed policymakers to indicate what their research needs were, right? Related to their strategic priority areas, but also related to what was happening in the ministry in terms of their policy agenda. So that was really useful for us, and that led us to develop our national health research agenda. And again, this might be more routine type of research to really pull out the evidence that is needed to inform policy questions. But that was quite useful for us. Again, the development of a national health research agenda, showing the priority of research topics, as well as the hosting of a reverse research day. Thanks.
You want to just say a word more about the idea of a reverse research day? It's an unusual term, Shelly-Ann, so maybe just explain a little.
So I think it actually started with Harvard University. I was corrected by my dean when I was saying it started with Johns Hopkins, because I know Johns Hopkins does it, the reverse research day. But I was corrected by my dean and said the concept actually started with Harvard. So it allows policymakers to get on the stage and share their research need with researchers. So in our specific context, we have 3 local universities, and we invited persons within the field of science and health to participate. Researchers were actually in the audience, and the policymakers were in the stage. Representation from policymakers came from all our strategic priority areas. So we had a representative for communicable disease, NCDs, health systems, and dental, oral health, and things like that. So they would be on stage and they're presenting what they need to answer their most important questions and to fulfill a particular need for their policy agenda. From that, we had persons working in groups to identify whether this research was already conducted and the policymakers are unaware of it, whether data exists and has not been published, whether they need data that the ministry can provide. We also got persons to commit to working in groups to develop a proposal that would lead to the execution of a research project. Post 1 year follow-up, that didn't happen, though that wasn't quite successful. But the data coming out of this reverse research day allowed us to develop our national health research agenda.
Fantastic, Shelly-Ann. That was a great explanation, and you're getting a lot of love in the chat and in the hearts flowing over the screen. So thank you. Tanja, I think Shelly-Ann's made some really critical points there, but you have a bird's eye view on this. Do you want to comment and provide any additional thoughts?
Yeah, I mean, it's very much building on what Shelly-Ann was saying. So providing opportunities for interaction, right? Whether it's the reverse research days or other kind of platforms that allow for researchers and decision makers to interact and for decision makers to voice their research needs is very important. But then also looking into how can we strengthen the capacities of researchers, of policymakers, I meant, to, as you were saying, Oliver, to formulate research questions or evidence synthesis questions. It's not only that in parts we're doing that with EvidNet, because when we have an evidence brief for policy, a research or a review question needs to be based on policy priorities identified. But we have other institutions such as the Epicenter at University College London, who are excellent in forming various groups, in fact, not only the users, and developing very concise review and research questions. So the capacity strengthening is there. Also tools that exist in this field. Again, our colleagues at UCL developed one on commissioning evidence synthesis. I know that UNICEF has worked on, because you mentioned implementation research, on tools for the users, how they can better use implementation research, but also commission it, etc. So that's one other big chunk where we can support, I think, decision makers in this field. And then lastly, not only to be reactive, as you were saying, Oliver, supporting the priority setting, developing a research agenda is, I mean, and you know it all because your team developed also a research agenda. But I think it's really important to prioritize which kind of research gaps are there, not just because there are gaps in research, but because actually they have policy priority. And linked with that also foresight exercises that is truly relevant for decision making. So I think these are different aspects, but just components, of course, of how we can strengthen decision makers commissioning the right research in a way that actually is going to fill their own research gaps for decision making. And maybe, Sarah, if I can quickly also get back to the other 2 questions that you mentioned, just very briefly, because I think AI has really become so important now with regard to evidence synthesis. It plays a very important role, and the methodology is and technology is developing very quickly here. But one of the aspects, and in many ways you said that already, Sarah, but I want to emphasize, is that the relationship building and allowing for brokerage, for deliberative dialogue, I think that is something I find it difficult to see how that can be replaced by AI. So I think in the space of knowledge translation, that's really something we can give a lot of work to AI when it comes to evidence synthesis. But then there are other aspects where I think human interaction is just very, very central. And lastly, after action review, we at WHO haven't done that very systematically following COVID. We did, during COVID in 2021, organize a major WHO Global Evidence to Policy Summit, where we brought different interest holders together, allowing for lessons learned and also the gaps that we saw for peer review of countries and of different actors to happen, informing following processes. But because you also mentioned health systems learning, we are in the process of publishing a new guide on health systems learning and also developing a community of practice here. So just if people are interested online in this space, we will soon have more available to that from WHO. Thank you.
Thank you so much, Tanja. There's quite a few questions coming in. I wanted to see if Alison Colbert was, Alison, you put a couple of great questions in the chat. If you'd like to unmute yourself and ask one of them, please do. And then I was also going to ask Maguette about a question that they have posted. Alison, are you there? Do you want to unmute?
Hi, sure. Good to see everyone. Gosh, which question to ask? I'm really intrigued by this discussion we're just having about the reverse research day. But my initial question had been sort of the inverse of that, about getting the evidence to policymakers in a timely way. And, we heard about, harmonizing tools and processes for knowledge and translation, but how we can strengthen the systems to get the evidence to the policymakers. But I think that also, again, like Oliver was just saying in this discussion, the inverse question, how to make sure the policymakers are getting the evidence that they need. Yeah. Thank you.
Thanks, Alison. Great question. Also a very big question. Maybe I can adapt it slightly and go around our panel and just say, if there was one thing that you could change in your current system to make sure that policymakers got the evidence that they need, what would that be? What would be the most critical one in your view? Anyone willing to take that one on? Shelly-Ann?
Maybe I can start. Access to policymakers. So you notice in my presentation, I said, Sarah, we wanted to develop a rapid response service. It has been done really well by the Knowledge to Policy Center in Lebanon, as well as the McMaster Health Forum. They're both WHO collaborating centers. And they really do have a good framework for rapid response service. I think Ethiopia as well, Firmaye, my colleague who's on the call as well, they have an established rapid response service. Our issue is really getting that access to be able to set up this rapid response service. I know Alison's question as well spoke about, how do we utilize these established frameworks during, emergency situations. And, a rapid response service usually starts with a question that a policymaker sends to the service. Once it's established and once both parties, policymakers and researchers, agree on this question, you move forward within 3 to 30 business days to provide a quick synthesis of what is available. So for us, it's getting in the door, being a part of these high-level committees, getting a hearing from our executive leadership team consistently and continuously. That's the one thing I'd change, because I think once we get inside, we'll be able to really sell what we can do, the importance of what we are doing, and the change it could make, not just for the ministry, but for the people of Trinidad and Tobago.
Fantastic, Shelly-Ann. So coming back to that personal relationship and the importance of it, and you have to get in the door to be able to establish that. So with about 140 people on the line, maybe we can begin to shift that culture. Who else from the panel would like to respond? One thing that you would like to see changed in your environment that would make a difference?
I'm happy to go next, Sarah.
Okay.
Yeah. I think one of the things that I would truly love to see change is, let me start. I think we have already gone very far when it comes to developing processes, supporting and working with many actors around the world, having a lot of learning improvement. But we can put a lot of systems in place. We can have a lot of mechanisms. We can have as WHO, a lot of norms and standards that we believe are working. But if we don't have the context right, if we don't have an enabling environment, meaning trust in science and really the political economy that allows for evidence to be used, then all what we're doing and investing in is in vain. So having such an enabling environment is, I think, really critical. We have seen through institutionalization processes, such as in Brazil, for example, where in the field of health, evidence is really institutionalized in terms of its use, that fortunately when political commitment in this field is decreasing, there are so many of these other pillars that I showed earlier in the institutionalization framework that were mature enough that they were able to maintain the system. So even if one of the pillars, the governance, falls away, the other pillars were able to maintain ongoing processes. And now that there has been for a few years a new government again, the process has taken off and has been reestablished. But the more there is this mistrust which is sown, the more the entire system is destabilized. And I see that as a fundamental risk to our world, and also in particular to the evidence ecosystem and the use of evidence in policy.
Thank you very much, Tanja. I think that that's a very salutary concern that many of us are really worried about, the sort of mistrust in science and people's understanding about how that's emerging. I don't know, Firmaye or Sam, whether you have any reflections, maybe brief reflections on one thing you would like to see change.
Yes, I can say very short thing. So I totally agree with Tanja and Shelly, and I would add maybe building the capacity of our citizens and the users to ask for the evidence to action process. We work, very hard on building the capacity of decision makers, researchers, but for us to bring in the real accountability, we see this working in election seasons, right? So why not bring this concept into building the capacity of our citizens to question for the use of evidence for action?
Great, thank you very much, Firmaye. Sam, any final reflections from you, and then I'll try and wrap up.
Thanks, Sarah. Based on what we've seen, I think one of the major change points that probably I want to see is a shift towards use of more living evidence pieces or living evidence indices, moving from more static use of evidence to more growing large data reviews in which we add value to what's already there, seeing a bit of transformation and seeing the people we require to make decisions and policies pushing for more of user-driven synthesis of this different pieces of evidence. So the focus sort of shifts from research organizations to more of the end users using this in their day-to-day policies and decisions. Thank you, Sam.
Thank you very much, Sam. And thank you, first of all, to Verena for being such an excellent co-moderator, but also to our wonderful panelists, because I think that you've provided really impressive sort of insight and understanding and really thoughtful reflections about what's going on in your country context or at the global level, and how best to respond to that going forward. I did want to make sure that people saw some of the resources that have been posted into the chat by different colleagues. There's some really helpful resources there, so please look at that before we close out. I'm not going to try to provide a comprehensive summary of everything that we discussed today, but maybe a few reflections. I think I was involved in WHO sort of in the 2005, 2006 when Epidemic got started, when some of these evidence to policy initiatives also got started. And first, I'm hugely impressed at sort of seeing how far this has developed over the past 20 years. And I think, all of the speakers today brought such insight. I think, there are a few key messages. Interestingly, that sort of personal relationship continues to be so critical, but I think we also had some really good lessons, particularly from Ethiopia, about how you begin to transform that personal relationship into a more institutionalized relationship between organizations and the different entities, so that it's not reliant on those personal relationships, which can be disrupted very easily by political change. I think we also heard a lot about specific tools and approaches, almost sort of regardless of that broader ecosystem, the things that we can draw upon, such as reverse research days or rapid reviews or living evidence documents, sort of newer and more interesting ways of summarizing and evidence and making sure that it's timely and in a format that can be easily used by policy and decision makers. Finally, I think there were some important forward-looking agendas that came out from this discussion. AI obviously being one of them, and figuring out how best do we use AI going forward so that it strengthens and doesn't undermine the evidence to policy process. But there were other comments as well about the need to better align some of the tools that we have got. So thank you all for an extremely rich discussion. I'm very sorry I didn't get to all of the questions in the chat. I think we simply run out of time. But let me hand back to Oliver for the last minute or so just to close us out. Thank you.
Great. Well, thank you so much, Sara, for leading all of us through the last hour and discussion, and of course to all the panelists and Verena for co-chairing. And a big thanks also to Tanja, of course, for really, putting all of this together as well. And I think it's just so interesting and important to see this conversation moving forward, as you said, Sara. It's clear that research isn't something that's distant from practice, and that I think obviously in the pandemic that was obvious to all of us, but actually in many other public health settings, it's true that the policymakers need research in a timely way, and the researchers are doing research because they want to make the world a better place, in essence, right? I mean, people want to have their research used for a positive outcome. So at least on the face of it, there seems to be an obvious win-win that we should be going for. But we're not there because of all sorts of structural challenges, I think, in the way that let's say, our societies are constructed, or at least our governments and our research organizations are constructed. So I think, this is an important part of the conversation. Of course, from the WHO Hub side, we're looking at this through a very specific lens. But of course, the issues that we facing through our area of focus it's just a microcosm of all of the issues that we all face in many different areas. So a huge thanks. We'll definitely be following up on this theme because I think this is so important. And as the questions in the chat demonstrated, we didn't have anywhere near enough time to get through all of the different aspects of this. So we'll just have to come back and keep going at it. So thanks very much for everybody for joining. Thanks again once again to the panelists and moderators. And I look forward to seeing everybody at the next session. Take care, everybody. Thanks a lot.
Bye-bye.
Recording stopped.